All right, folks. Well, it's Healthcare Unfiltered. And for those of you who thought we cannot get these two iconic legends in thoracic oncology on Healthcare Unfiltered, think again. They are here. And I'm really very thankful that you both took time of your busy schedule to be on the show, which I hope it's going to be very very dynamic dialogue, discussion, debate, and the beneficiaries of these are always the listeners to the podcast. We'll start with quick intros. You both are well known in the field of oncology, but maybe few folks still have not heard of Jack West and Nate Pennell. So, Jack.
Sure. Hi, I'm Jack West. I'm a thoracic medical oncologist, associate professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area. I'm also the web editor for JAMA Oncology. I do a few other things and just kind of follow and try to interpret the evolving landscape in the lung cancer world.
And Nate?
Yes, Nate Pennell. I'm also a thoracic medical oncologist. I've been pretty much my whole career at the Cleveland Clinic in Cleveland, Ohio, where I run the lung cancer program and also am the vice chair of clinical research. And just to set the scene in case people are expecting fireworks, Jack and I have been really good friends now for probably close to 15 years. And we actually enjoy sparring on topics. So I'm hoping today will be an exciting discussion.
We're committed to writing a piece together in the coming weeks that will kind of forge common ground. So even though we have some differences, I think it'll be as instructive to see where we converge as where we diverge.
Well, there goes my opportunity to get likes and retweets and everything. I mean, that doesn't work. I need I need more arguments, yelling, screaming, and some sound bites.
Talk about COVID. We could talk about politics.
As my significant other will, my significant other will tell you that I have a pathologic problem with arguing over everything, even with the people I care about. And so hopefully it will still happen.
Okay, excellent. Perfect. Okay, well, here's what I wanted to start with, because there are two concepts I want people to understand. Maybe I'm wrong, but I believe in two things. One is there's absolutely no perfect clinical trial. In fact, if you ever submit any clinical trial to any journal and you don't have a section on shortcomings and pitfalls of your own study, the reviewers will send it back to you and say, blah, 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 blah. That's one. And number two, I firmly believe there's a lot of things that we do in medicine and in oncology that is not based on randomized clinical trials, prospective randomized clinical trials. Am I off with these two concepts, Nate?
No, I mean, we live in the real world. It's not possible to do something perfectly. And in fact, the more studies try to be perfect, the less sometimes they apply to the actual patients that we see. And so I actually am a fan of relatively sparsely designed clinical trials that include a much more real world population. And we can hopefully understand a little bit more about how that will impact the patients that we see.
Jack,
I definitely agree with that. I think that, and I'll say that a couple of the editorial editor's notes that I've done for JAMA Oncology over the last few years have been on really the same theme of, in the land of the blind, the one-eyed man is king. Sometimes, very often, I would say just about every day in clinic, you have to make decisions that are not guided by randomized phase 3 trial evidence. And you have to use judgment and extrapolate from the evidence. And if all you have is retrospective and real world, that's not nothing. That's sometimes the best you're going to get and totally okay. I also think that we should dispense with the fallacy that the cross-trial comparison is anathema, because that's what we have to do in the real world when you have randomized phase 2 trials for RET inhibitors and MET inhibitors and you don't have a direct comparison. what are you going to do in real life? You're going to do a cross-trial comparison. So let's dispense with this delusion, this fallacy that that's not possible to do. I also totally agree that you can't have a prospective randomized trial that is perfect either. And besides the fact that you can't do that even if everything was static, we also have the fortunate challenge of our clinical world evolving over time. And these randomized phase 3 trials especially tend to take years. And so in the world of ADAURA or many others, this is against a background of a shifting clinical landscape. And so we have to acknowledge that that is part of the process. So I don't think we can aspire or should aspire to perfection. That's not, to me, the goal. It's really just trying to identify what are some of the more reliable, foreseeable challenges and try to at least accommodate those as well as possible.
So the first thing that always, when we talk about these trials that often gets heavily criticized, is control arms. To me, a control arm means that if I ask 10 thoracic oncologists, the 10 of them are going to agree and say, this is the proper control arm, which means that this is what all of you would use in thoracic oncology or any other discipline. But it's not always easy, but it's often being told that, the control arm is inferior, it's not the right control arm, and so on. How true is that? How true is this, Nate and then Jack, in terms of deciding on the control arm?
No, it's a huge problem. And especially when you have differing standards of care that change in different places in the world at different times. So I think the best example of this that I can think of is the innumerable immune checkpoint inhibitors versus chemotherapy trials in advanced non-small cell lung cancer. When the first ones came out, the Keynote 24 study and the 189 and whatnot, the standard of care was absolutely chemotherapy. And so you could say in 2018, when all of these papers were coming out, that was very appropriate. And then over the next 7 years, we continue to see multiple phase 3 trials being presented and published and submitted for potential approval of new drugs. Immune checkpoint inhibitor with or without chemotherapy against chemotherapy. And the argument is that, there are places in the world where chemotherapy is still the standard and immune checkpoint inhibitors aren't widely available, and therefore that's okay. And that is where, at least in the lung cancer world, we see a lot more contention about this, because we would say now it's been a good 5 years that immune checkpoint inhibitors are the standard of care for pretty much everyone with frontline non-oncogene driven lung cancer. And it really shouldn't be ethical to continue to do these studies no matter where they're conducted.
I agree with that. I think, you could use that. You could use ALK inhibitors and comparison against crizotinib, which is the same pattern. I think, the Crown trial showing that lorlatinib is significantly better than crizotinib is, essentially a foregone conclusion that is unhelpful to clinicians who have moved away from crizotinib for 3 or 4 years and have been using alectinib, where the clinical question is, and has long been, is there some incremental benefit to first-line lorlatinib compared to a second-generation ALK inhibitor like alectinib or brigatinib or something? So, and I also agree that with Nate that, the issue of chemo versus chemoimmunotherapy was extremely relevant in 2018 and 19. And by 2021 through 2023 became quite dubious as a control arm. So yes,
but Jack, what do you do? Like, you're doing a trial and then the trial comes from Japan or Europe that just changes the standard of care, maybe. And that was what you had in your control arm, the trial done in the US, let's say. Do you just stop it, amend it? What do you do? This happens a lot. Not a lot.
I think it depends where the trial is in its process. If you're 90% enrolled, you complete it and you just live with those caveats that this is not that informative. We do have trials, many trials of Nate and I and all the other folks treating lung cancer have multiple competing chemoimmunotherapy regimens that are legitimately considered comparable, and we just have to understand that there's no head-to-head trial, and that's why we're left with cross-trial comparisons or just going with our preferred one unless there's some reason to not. I would say that, we'll get into ADAURA as one of those situations where I don't think there's any question that placebo after chemotherapy was the appropriate control arm. The real nuance or question of the control arm is, should there have been more accessible access to osimertinib? And I would say that, when you're talking about the amendment in spring and April of 2020, that was when the data had been kind of released, and before that time, osimertinib was the standard of care, the preferred agent by NCCN, and overwhelmingly preferred in not just the US, but in most healthcare systems. That I would have hoped to see the mandating of crossover at that point.
And we're
so
gonna go.
Yeah.
We're gonna get there, because I think
Mhm.
in addition to the control arm, I think the second concept, I have two more concepts I want to talk about in general, and then we'll go into ADAURA. The second concept, actually, you already alluded to, Jack, which is the crossover.
Yeah.
And I think that, in what trials, Nate, like, we must do crossover versus trials where you think it's okay not to do crossover? I hear this all over the place in terms of doing crossover versus not. Is there a sense for you that certain studies must mandate crossover versus studies that are okay not to do so?
Yeah, it's a good question. This is, and we also have to differentiate crossover from subsequent treatment and trials. So, when we think about crossover, we're usually thinking about, say, an incurable stage 4 study where someone is receiving a new drug. I would say the areas where crossover is probably ethically mandated is when you've already got a pretty good idea that your drug is going to be a very effective drug. You've got maybe strong phase 2 data. You may even have, say, preliminary approval or something, and you're going to compare it against an older standard because maybe that's required for regulatory approval and whatnot. And you want to make sure that, in addition to showing that it's better from, say, progression-free survival standpoint, that patients have access to the drug later on. I don't think that every drug necessarily needs to be shown, to have crossover built in. Especially if it's a really open question about your drug is better or not, why would you even necessarily want to have patients get access to that later on? For adjuvant trials and other things, it's a little bit different, because really what you're doing is you're looking to see the impact on cure rates and disease recurrence. And so, at that point, depending on what your primary endpoint is, it's not exactly the same as crossover so much as how much influence you want to have on subsequent treatment after the patient's no longer on the study. So that's a slightly different discussion, but certainly relevant if we're going to talk about ADAURA.
We will, but I want to, like, the concept of crossover, Jack, in your mind, do you agree? Like, when would you feel strongly about it?
I would say that if the treatment has certainly a proven benefit and is a standard of care in the later setting, whether that is as treatment for relapse disease, in patients who relapse after early stage, or if you have a first line trial and you have a treatment that is approved, demonstrated to be significantly better in the second line or later setting, that is also a setting where crossover should be pursued, because it is widely available, or should be widely available, has a proven benefit. In the trial, say, Keynote 042, that was chemo versus pembrolizumab for a broader population that included patients with PD-L1 low as well as PD-L1 high. There was no crossover permitted in that trial, and patients in the US and many other parts of the world had immunotherapy as an approved, proven standard of care with a 3-month survival benefit and median overall survival compared to docetaxel. So at that time, immunotherapy after chemotherapy was an unquestionable standard of care. And I would say a real problem to not have that be available to people without jumping through great hurdles to get it. So these are settings where when you have a therapy that is proven of benefit, and you're really looking at timing, or should be looking at timing more than access. Anything going from being tested in the first line compared to second line or later use, or in the setting of ADAURA, earlier versus available to people at relapse, I think is where you want to have crossover. Not in a setting where it's of unclear benefit at all, but where we would routinely be pulling it off the shelf and have the availability to do so in much of the world based on evidence. It should be about timing and not about access.
How about endpoints? That's the third concept I want to talk about. Overall survival, progression-free survival, disease-free survival, whatever. Do these matter in the adjuvant setting versus metastatic setting? And in terms of how you design a trial, Nate, in terms of deciding on your endpoint, is there such a thing that if it's an adjuvant study, overall survival is a must endpoint? I think you got the question I'm trying to ask.
No, absolutely. And this is an important concept. And I would say, I think everyone accepts that the most important endpoint is overall survival. That's what we call our gold standard. And everything else is used as what we would consider a surrogate endpoint for overall survival, with the assumption that an improvement in that surrogate will lead to an improvement in overall survival. And sometimes that's been proven to be true, and sometimes that's just an assumption. And it has a lot to do with how long it's going to take to get the answers. And so, FDA, for example, has been very clear in that they support the use of surrogate endpoints because they want to get drugs approved and available to people when they have a reasonable chance of improving people's survival, but they don't yet have that overall survival information. So for something like ADAURA, we know that, one, the treatment is going to be 3 years of treatment, and then you're going to have some follow-up afterwards. We also know that for people who recur with metastatic disease, that the median overall survival, even in incurable stage 4 disease with osimertinib, is 39 months. And so you can just add up the numbers there and see that you're probably talking about, 5, 6, 8 years before you would have mature differences in overall survival from the beginning of a trial. Whereas you might know very early, within, as we saw on ADAURA, 24 months on the study, that there may be a big difference in the surrogate marker of disease-free survival. So it's really depends on how much you believe that surrogate endpoint is truly meaningful and truly is likely to lead to an improvement in overall survival. And I think that it is very appropriate in studies where there is very long potential overall survival to report out these surrogate endpoints and try to make decisions based on those, with the caveat that you always have to, make a clinical decision about how meaningful it is.
Jack, maybe this is a good segue to just start talking about ADAURA a little bit more in detail.
Well, I think it's actually helpful to talk about ADAURA perhaps relative to others, because we do want to have this be of general utility. And I think ADAURA is one trial in the universe. It's an important one that I think illustrates some points and is different from others. I think so. It was, I think, on your podcast with you, me, and Nate 3 years ago that Nate made the, I think, very appropriate point that it's not just positive for progression or disease-free survival. It was enormously positive for that, and that should count for something as heralding a highly probable improvement in overall survival. And honestly, I conceded then, I think that's a very fine point, that it, for years since then, I have been offering and recommending osimertinib in this situation without overall survival yet, but based on knowing what we know with those limitations, I think that a hazard ratio in the 0.17 or 0.2 range for DFS is amazing. And I think one caveat about that is it is in the middle of the treatment period, and Nate's been one of the leading people doing this research for more than a decade on adjuvant EGFR TKIs. I think one of the problems that we should have about DFS as an endpoint is, work he has reviewed and been part of has clearly shown that other EGFR inhibitors improve DFS but fail to improve overall survival. And so this was known. It's been known for a very long time, for a decade, that lots of EGFR inhibitors will have scans look better, but they do not improved overall survival, which I think should have been a reason to at least co-prioritize, if not greater prioritize, overall survival. Not to mention the fact that overall survival, I think, should be the endpoint above all others in the curative setting. But we knew that EGFR inhibitors up to this point worked while you were on them and failed to give a sustained benefit beyond that. And I think that, yes, it's very easy to envision that osimertinib could be increasingly effective for micrometastatic disease. I would find it very conceptually believable that the benefit is longer lasting and potentially survival conferring, even if it's for a finite period and stopped, but greater in the adjuvant than in the macrometastatic visible disease setting. But I would like to just get the data to see that and not have that subverted by the FDA. I think the FDA does have a policy of, if it is plausible that there could be a benefit, we're going to wave it through. And I think that it is erring on the side of being overly generous in that, in contrast to ADAURA's DFS benefit, which is tremendous, we have approvals for adjuvant immunotherapy in the last year that have been as underwhelming as ADAURA's has been overwhelming. I mean, we have approval for Pembro based on a DFS benefit of 0.77. That is a total yawner and doesn't even have a pretense of an overall survival benefit, but we're still offering it. And I think one big problem with FDA approval is their policy is, we just want to make everything available and the doctors can decide. Well, that's fine, except physicians in practice are not generally that nuanced in their discussions. They feel that if it's FDA approved, it should be done. And that's not what the approval is predicated on.
But
Right.
And the issue that, go ahead, Nate.
I was going to say, well, first of all, shockingly enough, I'm completely in agreement with Jack on this. The ADAURA study, there was a 0% chance this was not going to improve disease-free survival, because we already knew that TKIs did that. The question was it going to be a big enough difference that it was actually going to eventually lead to overall survival? And so this is one of those things where, you look at 60 patients with ROS1 positive lung cancer and you give them crizotinib and 80% of them respond. You don't need a huge amount of data to see that you've got a winner there. And so when the ADAURA comes out and you've got a 60%, or like a greater than 50% absolute difference in recurrences in the first 2 years, you look at that and you go, well, you know what, people might want to know this and might want to start thinking about using it, because this is such a huge difference that I never really had a doubt that it was going to eventually lead to overall survival, although I definitely wanted to see that. But I agree with you. I mean, the perfect example is the adjuvant immunotherapy trials, which have a I would say a much more typical difference in disease-free survival for what we expect to see in the past from our old studies of, modest disease-free survival that don't lead to overall survival changes. And we shouldn't be carte blanche just approving and using drugs based on surrogate endpoints that we don't have a really strong feeling are definitely going to lead to differences in overall survival. Because in the adjuvant setting, that's really what you care about, is improving survival.
And then with immunotherapies, you even have subgroup analyses that are showing that there is no benefit for adjuvant atezolizumab for PD-L1 1 to 49. FDA approval is there based on DFS. We have overall survival data showing there's no benefit, and yet people are doing it, just because it got, waved in, carried on the back of that high PD-L1 group.
Yeah, I think you're both arguing for more rigor in terms of FDA approval, which I think we are all, I think that's actually different, probably podcast, because I do hear, to Jack's point, folks saying, let there be access to these drugs and have the physicians decide. And I think there's merit to this, but again, to your point, not every physician is going to look at the nuances of each particular therapy. But to me, what was pretty surprising, so the ADAURA trial, and I think all listeners heard of this trial, and I'll do some intro on it in the beginning. I did some intro on it. Despite the overwhelming, enormous DFS that Nate alluded to 3 years ago on this podcast, and despite the fact that overall survival was also positive in the last follow-up, I think there was still many dissenters to this trial. And I want to get into this a little bit. I mean, to me, it was like a no-brainer. This was a huge win. It was, I was a little bit surprised by how much chatter was about the possibility that this was a poorly conducted study. And I'd like to hear from both of you, because obviously, Nate's opinion was that this was well done trial, and the results were overwhelmingly positive. And I think, Jack, you were opposing that a little bit and suggesting that there are certain elements of the trial that were not done properly and could have been it wasn't perfect, let's say that. So Nate, do you want to provide your opinion about the ADAURA trial, and then we'll hear from Jack?
Sure. Yeah. So a few years ago, we discussed that it clearly dramatically improved disease-free survival. And we saw some updated data that it reduced CNS recurrences, which actually continued on over time. At the beginning of this year, we saw a longer-term update on disease-free survival, which did, as anyone who studies these studies, this type of study knows, did show some closing of the disease-free survival curves after stopping at 3 years. Although most of the difference was still preserved going out to 5 years. And then finally, we saw the overall survival results showing that there was a 10 to 12 absolute difference in overall survival at 5 years, depending on whether it was the intent to treat 1B to 3A versus stage 2 to 3A difference that seemed to be widening as time went on. And so I think that this study was done very typically for this type of study. I think there was nothing unique or special about the way it was designed. I think it was conducted as well as it could have been. I think the company did the admirable thing in 2020 when they saw that there was a big benefit in saying that they were going to give access to the drug to the people who recurred. Obviously, that didn't lead to everyone who recurred getting the drug, but I think that we can certainly discuss the problems with what happens with a long-term trial with changing standards of care and differing treatments at recurrence and how that might impact the final endpoint. But ultimately, I don't think it changes the final conclusion, which is that giving adjuvant osimertinib makes a huge difference on recurrences, that some of them appear to be durable reductions in recurrences that lead to a very clinically meaningful difference in overall survival. And that's, and I would like to start using what we've learned from this to start designing hopefully the next generation of trials so that we can improve on what we've learned here.
Jack, what were your issues with the trial?
Well, first I'll say I agree the trial was positive. I think it, was highly likely to be positive, as I already mentioned, that when you see this DFS benefit, I think that it was not hard to envision that it was going to be enough of a benefit to, even if it eroded, to translate to a survival benefit. So even with its imperfections, which I think are real and should be examined critically, I don't think it undermines the overall conclusion. I think that my real issue stems from osimertinib being clearly superior to other agents in the class. And that's really the issue, that this has been, continues to be so much better than gefitinib or erlotinib or other things that were previously given in the first-line metastatic setting, that I think it was too good to not make available to people. Now, so the issues. One, I think, as we already talked about, I think DFS was a very dubious primary endpoint because it's not the one that we should care about most. And we had many prior trials with EGFR TKIs that underscored with great clarity and consistency that it is not necessarily tethered to overall survival in this setting. Even if it could be, nothing about the prior work suggested that to be the case. So it was a poor presumption to make. But with the benefit that was seen, I think it would have been, it was very appropriate to present this and as we have kind of moved forward with it, but still at least make it a mandated crossover, because at that time and before that time, osimertinib was around much of the world, and according to AstraZeneca marketing, the unequivocal best treatment for metastatic, relapsed disease. And it was what Nate and I and almost every other lung cancer oncologist or general oncologist in the US was favoring, and not just the US, but in much of Europe and everywhere that you could get it. So I think that had the trial been what we called for in 2020 in the wake of the initial data, was great, just make it crossover and a test of timing, and I will be praising it from the hilltops. As early is better than late, that's worth knowing. It was not that trial. And at the end of the day, what we saw at the plenary presentation, which I think deserves to be scrutinized, is that the only 38.5% of patients who had a relapse on the control arm ever got osimertinib. So yes, it was.
But they got something.
Yes, but getting a known inferior agent shouldn't be anything to be proud of. I think that is, we knew better. Everyone knew better. AstraZeneca unquestionably knew better, because they were promoting heavily that there was a best therapy and osimertinib was it. And yet, what I think, when you have 56% of patients getting a known inferior EGFR TKI versus 38.5% getting osimertinib, this clarifies two things. One, your crossover option had plenty of resistance to it. That obviously these were people who could not realistically access it. It was by request only. And at the end of the day, it was hard to do. 22% of people got chemo. Who wants chemo in this setting as opposed to an EGFR TKI? So when you're getting a known inferior TKI 56% of the time compared to 38% with osimertinib, and 22% are getting chemo, you're getting an inferior crossover design. And you're clearly showing it's not just attrition, that people came in a wheelchair and were unable to get treatment, which is a question. Would people be experiencing brain metastases and coming in with leptomeningeal disease? That wasn't the case, because if you're well enough to get chemo or a different inferior EGFR TKI, you're well enough to swallow an osimertinib pill. So this is problematic. And I think it illustrates that a significant unknown component of the benefit that was seen is because these trials are being largely conducted in enrolling patients who are just getting clearly inferior management outside of what is controlled by the trial. And let me also mention, we haven't talked about staging, but the trial didn't mandate PET staging. You had patients with stage 2 and 3A disease. There wasn't mandated
we'll get to
brain
staging.
MRI. But I mean, the fact is,
I just want to get Nate to respond to the first, then we'll go to staging. Because I think Jack brought few points pertaining to the inferior therapy and the chemotherapy. The one, Nate, in your response to this, this is just to help clarify to me, the inferior treatment to osimertinib is just in the metastatic setting, right? I mean, there has been no comparisons of 2 EGFR inhibitors in the adjuvant setting. So all what we know is osimertinib is superior when treated.
But these patients present with metastatic disease.
Yeah, so
when they relapse, it's not adjuvant.
Right.
It is. They are getting.
They
should be getting the therapy that he and I would provide.
Okay.
That
so
patient
Nate,
in our clinic.
That's a very good point. So Nate, what are your thoughts there?
Yeah, no, I mean, I see this. I certainly have always understood that this was Jack's and other people's major criticism of the study. And so I think it's, this is why I would say, this is certainly a point worthy of debate as to how this would affect things. And I think it's a larger issue in terms of where we conduct our studies these days that lead to the approval of drugs that are principally used in rich countries, but then they're not actually enrolling patients in the countries where the drugs are being most widely used. I mean, that's a big issue. So a couple things though. So first of all, the study was designed in a very typical fashion for an adjuvant trial with a primary endpoint of disease-free survival. And so what that means is they enroll people, they give them the placebo or the drug, and then when they recur, they've hit their primary endpoint, and those patients come off trial. They're followed for a short time for any toxicities that might follow for that. And then after that, they're followed for overall survival. And that's it. That is the design of the study. Okay, so the study is not, these studies are typically not built to treat and follow and collect data on patients for the lifetime of the patient until they die. The way they would perhaps in a stage 4 study. And so when people keep talking about crossover, there isn't really crossover in these studies the way they are built. Now they could be. You could have designed the study with a primary overall survival endpoint. You could have said, we really care about whether early versus late osimertinib makes a difference. And you could have said, we will follow and mandate treatment at recurrence with osimertinib, and patients will stay on trial and we'll follow them for that. But that isn't the way it was done, and that's not the way, to my knowledge, any adjuvant trial that I've ever seen has ever been done. And so the company really wasn't doing anything different from what people usually do with this. The second question is access to osimertinib. So, almost 90% of people in the placebo arm, when they recurred with presumably metastatic disease, did get a TKI. We actually don't know what percentage of people who recurred got some treatment. We know what the numbers of patients who got treatment are, but there probably were some people who presented with leptomeningeal disease or a broken femur or something and never got treatment and may have died, and that may have contributed to the difference in overall survival. All we know is of those who got subsequent treatment, 88% got an EGFR TKI, and that 43% of those got osimertinib. We also know that when the trial started, that osimertinib was not approved and available in a lot of places, and it became available over the first, a couple of years into the trial, and that percolates through the rest of the world and becoming available. But even though they're available, it doesn't mean that it's actually still widely used in a lot of these countries. And so there's no doubt that this is an example of unacceptable disparities between the kinds of things that we in the United States widely have access to and a lot of other places in the world do. And sorry about that.
That is a good point, though. But I mean, is it something I kept hearing on social media and in the press that this is something that AstraZeneca must have provided to the patient. It was an obligation of the sponsor to assure that every patient is being offered osimertinib. Is that what usually happens in the adjuvant studies, Jack and Nate?
I don't think it is. I don't think that this is, I think if they had done that, we would have been like, wow, that was really noble and great of the company to provide their, best in class, expensive drug that's standard in the US and given it to everyone. And they didn't until 2020 when they saw there was a big difference, and they perhaps heard some criticisms about this, and then perhaps that might have led them to offering it at that point. So again, that's a different discussion. I don't know that I would say that they were deeply unethical by not doing that, because I don't think that was considered standard at the time that they designed this. I do think it's relevant to discuss how that might have impacted overall survival, since slightly less than half of the people who recurred with metastatic disease got, perhaps an inferior TKI. I think it probably had a relatively minimal effect on overall survival, because there's not a huge difference in overall survival between stage 4 patients treated with osimertinib and older EGFR TKIs. The hazard ratio in the frontline trial was only 0.8 for overall survival. We know that the people in the osimertinib arm who recurred actually got osimertinib or got TKIs at an even lower rate. It's possible that their doctors may have felt that they weren't going to benefit from subsequent treatment, which we think is probably not true in people who recur after stopping adjuvant treatment. So, there's a valid argument to be made that could have had some impact on it. But ultimately, I think the overall survival was because fewer people were recurring, and fewer recurrences lead to fewer people dying of cancer. But yeah, I see Jack's point, and I think it's an important question, but I don't think that it makes the trial deeply flawed.
Jack, does this? I wanted to respond to this, but in your response, I wanted to address: does this make ADAURA unethical trial? Because that term bothers me a little bit, and I'm moderator here. So I want to make sure you address this. It has percolated a little bit all over. And I think, accusing a trial of being unethical is a big accusation. So I'd like you to address that.
Yeah, I would not go so far as to say it is truly unethical based on the standards of what is typical. I agree with Nate that it is not necessarily the typical approach or the least that is required, or it is not less than the least that is required. I think that the real issue to me is, yes, we have a system that allows you to pursue primary endpoints that are less than what should be really clinically valued as the best ones, that are, what is the threshold for regulatory approval is dissociated from what we should want or expect. And that at the same time, the historical standard of what you can do as a company to run a global trial is a lower standard than what we should consider to be truly optimally ethical. And I would say if it isn't unethical, it is not optimally ethical. I would say that when you run a trial in parts of the world where staging is demonstrably inferior and knowingly is going to have patients with subclinical stage 4 disease because you didn't run a PET or a brain MRI, and you then give them placebo, we know that they will have a worse DFS than patients who did not have stage 4 disease or got osimertinib. We've already run FLORA and know that not just is it better than first line, it's better than placebo. So for all the patients who had a don't ask, don't tell staging workup, which we don't have a clear sense of what proportion didn't get a PET with stage 3A disease or a brain MRI, that would be standard of care, not just in the US, but in much of the world. And we clearly considered not doing that substandard. That was permitted. That is,
Jack, quick question. Yeah, quick question. In ADAURA, all patients underwent surgery, correct?
Yeah.
And obviously most of them got chemotherapy, I believe, and maybe
The
there's
majority, it wasn't
the majority,
mandated.
right?
Yep. Mhm.
My question to both of you, and I hope this is not a dumb question, but since we do the MOC and recertification, I need to know, guys, I have to understand all of these things. Is it standard of care in the adjuvant setting, post-resection or even before resection, for patients to undergo MRI of the brain in the absence of symptoms? Like, do you do that on all patients or just 3A patients, like stage 1 patient?
I think Nate and I, we're just talking about facts here. I don't think there's much opinion here. I believe the NCCN guidelines call for these tests to be done for patients with stage 2 or higher.
Okay.
I think it's an
that's
Although
okay.
that is prior to surgery, though. So this is
Yeah.
part of the problem with this study is they enrolled, after surgery and potentially chemo. So the studies that would be done after someone had been staged, had surgery, and then potentially got chemo would have been most likely, in the United States, would most likely just be a chest CT.
Yeah. The other thing you can make an argument, if you had, I get the point of occult brain metastases, but just to play devil's advocate, if you are a patient who has undergone surgery, followed by several months of chemotherapy, that's probably not like after recovery, that's like 6 months. So if you had some occult metastases, they would at least appear, right? If you know, 6 months with
well,
occult
first of all, it's
metastases?
not. It wouldn't be. It would be. You're talking about, what was it, Nate? About 70% of patients got chemotherapy. So
it was about 70% of stage 2 and 80% of stage 3 patients.
Yeah,
got
and
chemo.
and a lot less, less than 50% of patients with stage 1. So, it was about a third on the trial. So, but you're talking, that's 3 months of treatment. And I don't know that there was even a mandated imaging study after surgery.
But Jack, 3 months after, you get a couple of months break after surgery, you get a thoracotomy. You get a lung resection. You're not going to get chemotherapy next week.
You typically get it, 4 to 6 weeks after.
Yeah.
So, yes, but if you had micrometastatic disease, or it was, you had disease in, some soft tissue or something, and 3 months later, I don't think that that's the case, that you would presume that it would remain, that it would have to be clinically apparent and symptomatic, because there was no built-in scrutiny looking for disease after the surgery. So I think if it was clinically occult and a patient underwent surgery, unless you had a seizure, you could have disease, and it could have been quite small, but quite clinically significant as metastatic disease. So I don't think that obviates anything. But, I think that at the end of the day, to get back to, I think, the meatier question, I think that the issues are, I believe, should distinguish between what was considered to be, indefensible or unethical, and what we should hope for and consider optimal for true eliminating disparities. Because when we have a trial that is run globally and has patients not get the staging that would be done in the US and not get the treatments that would be given in the US or Western Europe or many other places that we know are the best treatments, it's not a question. When we permit that to happen, I think that this is tacitly exonerating the company and the oncology community that this is okay. And we have a chance, when we run trials, to have the sponsor company just pay for the staging studies, which is a tiny drop of the cost of a month of osimertinib, let alone 3 years of it. And to run a trial that, therefore, if it had been done in a way that is not otherworldly perfect, but just demonstrably, clearly, evidently better, it would have been just a way superior trial, one that that Nate and I would be speaking in unison, full-throated, saying this is way better because it shows that early is unquestionably better than late. I would love to speak with one voice on this, but the reason we have some differences is just the issue of they didn't do the things that were foreseeably way better, that would have not exonerated the problems that and perpetuated these problems, but would have improved the care for the patients and not capitalized. Because I think that the other thing we should acknowledge is when these trials are run in a way where the staging is clearly worse and the treatment off protocol is clearly worse, and many, if not most of the patients are enrolled from those systems and not the places where they're going to be marketing it afterwards, those biases are all overwhelmingly in favor of the experimental arm. And I just think that we need to be honest about this. It doesn't mean that the trial wouldn't be positive, but I would just love to be pointing to a trial that is positive, even if it doesn't have a hazard ratio of 0.49 for overall survival. If it was 0.67, I would be very, very strongly in favor of this if it hadn't taken those what I consider to be shortcuts or ethical choices that just happen to be what are not the best choices.
But I want to have Nate respond to this, and then I have a comment about the financial thing and negotiations with sponsors on trials. Go ahead, Nate.
Well, I just want to say that I completely agree, and this is a huge issue that I don't think we hear discussed enough. Is most of the patients who get accrued to clinical trials that lead to approval of the drugs that we use that are very expensive and very effective and whatnot are accrued in countries that those patients outside of the clinical trial might never have gotten access to those drugs, even later on as part of their typical health system. And companies are opening and accruing studies all over the world, especially in places that have relatively limited health systems and access to care, because it's much less expensive. They can get a lot of patients enrolled on them. And in some of those countries, patients are enrolling on those studies because that's the best way they can get access to really good medical care. And that is really a terrible thing. It speaks just horrible things about the disparities in access to the types of amazing advances that we're making in cancer, and that people worldwide are not getting access to good biomarker testing, good staging studies, optimal surgery, really good, effective adjuvant consolidation, or even treatment for metastatic disease. And those patients are leading to the advances that are allowing us to then access these drugs. And that's something that I think is a massive issue that doesn't get discussed enough.
And that this is, we don't want these trials to be positive because they are run in places where the disparity is with prevailing care.
Yeah, I think that is to some extent a concern, if the staging is substandard. I think in places, like you said, where for early stage patients where they can't access the optimal treatments at metastatic recurrence and how that might impact overall survival. I have a bigger problem just with the overall ethical issue of that this is how trials are being run and this is where all patients are being accrued. I'm less concerned that, for example, in ADAURA, I despite all of these, I don't think that ultimately changed, the interpretation of the results very much. I think it's just more of a big ethical issue about, is this the way we do this? And the FDA mandates that some patients are enrolled, and this is I don't know if people realize this. The FDA requires that some patients be enrolled in the United States on these trials. And so what happens is companies open the studies, enroll 90% of the patients in, countries like we're talking about that are lower middle income countries that have limited healthcare systems, where they enroll patients very quickly. And then they put a small number of patients in the US on to say that they are broadly applicable across multiple populations, and that's good enough. And the reality is, but the flip side, of course, is it would be unmanageably expensive to do a 800 patient phase 3 study exclusively in the United States, considering how much bureaucratic burden we have and how expensive it is to run trials here. I mean, there's a reason why companies are doing them ex-US, and that's partly the fault of the healthcare system in the U.S. as well. So this is a massive problem without good solutions. But I'm glad that we're getting a chance to highlight it.
Them. Yeah.
Yeah, and Jack, going back to your point in terms of the additional cost of imaging, I mean, we all have run clinical trials, and you see how the negotiation goes when it comes to the cost. And most academic institutions will add 25 to 35% overhead to the cost of enrolling one patient, and not defending that how costly it is, but Nate did, again, we add so much barriers to it that you wonder actually if we bring those down, would that lead to more trials being conducted in the US? I don't know, have the answer to that, but I believe there's an opportunity there to improve on it.
No, there absolutely is. Yeah, I mean, we enroll a tiny fraction of people in the US to clinical trials. I mean, it's less than 10% of people enroll in clinical trials, despite the fact that that's really, people get better care on clinical trials. And a lot of that has to do with the bureaucracy and the difficulty of doing clinical research in the US right now.
I totally agree. I think there's just literally there's a lot of room between token US enrollment, which is essentially what we're talking about, and literally just token enrollment, because I think we are talking about the 80-90% enrollment from lower middle income countries, and having it be overwhelmingly US, which I think our system is a travesty. It's a temple of inefficiency and cost waste. And if we could improve that balance, and then maybe look at subgroups and see if there's significant differences based on where patients are enrolled and other patient characteristics, that would be informative. But I think that we can't ignore that the system as it is now is not only more cost effective, but it has several strong biases that favor the investigational arm when you run a trial in these other places. And so I think that we just cannot ignore that this is a very convenient truth for these companies as well. It's not just, I think, about the prohibitive cost, but that it wouldn't be this way. They would not have this imbalance if it disfavored the investigational arm rather than favored it.
I'm gonna finish with I was trying to find it, I couldn't find it, but you probably both have seen it. Adam Feuerstein, he's a reporter for Stat magazine, which I actually like that outlet. But as you and Jack were having these banters on Twitter, he tweeted something that made me laugh. He said, he just tweeted another trial, and these two, like he put in a tweet saying it's, the year is 3050 and a trial came out, and we still have these two arguing. I don't know if you remember this, but it really made me laugh.
Oh yeah. We have colonies on Mars, and Jack West and Nathan Pennell are still arguing about it.
Yes, exactly. I mean, it was really funny. So but I can't really find it to quote him exactly, but for folks who see you, I guess, on social media, I mean, I think sometimes it's, we kind of feel that you are in each other's throats, just like, almost getting ready to kill each other. So this is an opportunity to tell people who are listening to the show what you're planning on writing about, and how, do you agree more or disagree more on certain things pertaining to thoracic oncology? Maybe we'll start with Nate and then Jack.
I think in substance, there is very little space between what Jack and I think in terms of how we treat lung cancer patients and how we interpret the results of clinical trials. I think that there's a big difference in how passionately we state our opinions publicly about things. I think I tend to be a little more conservative and measured in how I put myself out on social media and my reaction to things. I made something like, oh, maybe concerns about something like that. And Jack will come out and be like, I can't believe they did this. It's unbelievable. unacceptable that they would do, and it's and I love it. I really love his passion. Sometimes I get on the wrong end of it, and that is led to some conflicts in the past, but nothing that we haven't been able to overcome.
I found the tweet, Jack, before you respond to this. It's Adam Furstein. He says, it's the year 2167. The first ASCO meeting held on Mars has just concluded without a hitch, despite rocket traffic from a nearby Taylor Swift conference at an orbiting stadium, and Nate Pennell and Jack West are still arguing about ADAURA. That is funny. You got to give him that.
Oh, sure. Yeah. I mean, somebody, I think
it got 26,000 views.
Yeah. Well, somebody had said in the comments that they thought it was in poor taste or offensive. I didn't. I thought it was just funny. And I mean, I'll just say we've already talked about how I think at its best, I'm actually concerned, disappointed, and, just wary about what's going to happen with X/Twitter, which I think has been losing momentum as it becomes it changes its personality. And I'm hopeful that the medical community will stick with it and not succumb to the political challenges of it. But I think at its best, Nate and I over years have, we've debated, and sometimes it gets heated, but honestly, I think it is the very best of what you can get from public discourse. I mean, Nate and I sharpen our arguments and refine our views. I have mentioned that, when Nate said on this, or he said on other things online, it's the magnitude, and you got to deal with the probabilities. That and other things have made me reflect on things I've said and think differently. And I don't think that's wishy-washy or flip-flopping. I think the very best of academia and science is incorporating new data and seeing things differently rather than being completely wedded to them. And what often happens is that Nate and I, regardless of our different styles of communication, end up seeing enough of the other person's side and finding common ground. I mean, we are going to be working on an article together that's going to talk about some of the victories and challenges of ADAURA, and I come away from this encouraged that we are more similar than different. We may emphasize somewhat different things, but I think we both see both arguments here. I mean,
can I say one quick thing, though? I want to say on our last debate on ADAURA back in 2020 on this podcast, or on one of your podcasts, I was resoundingly informed by everyone that I lost the debate to Jack on that. And yet, in the debate, he clearly said, yes, I will use osimertinib based upon these results because they are so overwhelmingly positive. I'm like, well, how could I possibly have lost the debate when he basically conceded it? And yet still, because he's so passionate about these other topics, he ended up...
I think
it wasn't from me. I mean, I didn't
I think
say
my
that,
issue
and
is social.
I don't think should be against each other necessarily.
Yeah, but as the moderator of this podcast, and I think my issue with social media is actually the fact that there are many patients, family members, and others who actually watch and read these discussions. And what I worry about is when we heavily criticize a particular trial, and as we started, no trial is perfect, and you are a patient or a patient advocate or a family member, you start thinking, my gosh, these are evil people. AstraZeneca is evil for doing this, or I received inferior care, or I wasted my time in a trial. That's where I want to make sure that whatever discussions we have, we need to be cognizant of the fact that there are patients out there who are really reading every word, and words do matter. That's my issue. And
I will say that part of the reason I got so passionate on Twitter about the discussions around ADAURA this year is I was seeing some of the discussions getting to the point where people were beginning to reply, oh gosh, I'm not convinced now that this is really beneficial. I'm not going to necessarily recommend this to my patients. So I'm like, whoa, we can have a discussion about how important this is and what things might, but I don't want to overlook the science of the trial and what it shows. So that was part of why it got as heated as it did.
And Chetty, I understand where you're coming from, but I think we all need to acknowledge that the physicians, the sponsors, patients, as stakeholders, we don't have completely resonant goals here. And the fact is, the companies are running their trials. Their goal is to help patients, sure, but it is to get an indication, a positive trial that will lead to use. And if the longer you're on a drug, especially if it's expensive, the better for the company. And, there is a goal of, the primary goal is to meet the minimum requirement to get approved. And then as long as it is credible enough to be used by the community. And I would just say, as the oncology community, we need to acknowledge, to examine when the minimum required to get approved and put a bullet point on the conclusion slide that X is the first drug to show Y and should be used all the time based on an endpoint that we didn't decide is the best one, but in closed meetings with FDA, they did. That is not the same thing as what is clearly best for patients. And that we should maintain independence about and not be just waving our hands and blindly accepting that because FDA and a company have considered something acceptable that we should accept it at face value. So that's why I think we should think for ourselves. And I don't think that raising questions is, sacrilegious.
This is a great way to end this podcast. I really appreciate you both coming in. You're going to come back again, maybe next year, maybe in a couple of years. Because
I will tell you, I've worn out my T-shirt from my last time.
Yeah,
on,
well, then it's time to send new T-shirts.
I'm going to suggest we talk about something not ADAURA. So
Well, we did talk about other things as well.
I know we did.
Hopefully we will. And then,
but I think that we shouldn't just reprise this every 2 or 3 years.
No, but
look at
I think this was needed. I feel like this was needed, and frankly, I had a lot of requests, honestly, from listeners to bring you both on, and it was very clear that there's a need for it. And I appreciate you taking the time, and time to send new T-shirts. I just need the addresses. And don't forget, get your MOC questions right. Osimertinib is the right question right now.
Yeah, well, the problem is that it may still be too ambiguous to figure out what they're asking. So even if you know all the data, that's the problem I have. Okay.
Thank you so much for coming on.
Great seeing you guys.